I actually want to start with my acknowledgements because I realized I'm always tweaking slides right up to the last minute, and I realized I forgot an acknowledgements page. So I want to be sure I acknowledge a couple of people before I start. One of whom is here. Mark Bondi has been extremely helpful to me in trying to problem solve as I've run into problems with the study that I'll tell you about later. Also, my study coordinator on this, Allison Moore. Christina has been wonderful in helping me try to tap into the ADRC registry and allowing me to make one of those videos last year. So I want to thank the whole ADRC for that. What I thought today is I'll talk some general about loneliness and contrast it to social isolation and social support. I get kind of wonky in terms of measurement in that way. What I mean by that is I'm always interested when we have these constructs and then we look at the measures and see, okay, what is it we're actually measuring? So maybe because it interests at least one of my audience, which is me, I'll talk some about difficulties in measuring loneliness. And I'll give you some background of why we should care. And then I'll talk about this feasibility pilot study that Christina mentioned that was funded as an administrative supplement to a larger study. So as Christina mentioned, the main thrust of my work in terms of loneliness right now is with serious mental illness, and I have an ongoing R01 through the NIMH, but they had released this call for administrative supplements to potentially generate NIA relevant R01s that would take advantage of or leverage the infrastructure of R01s from other institutes. So that's what I've done here is I've got this feasibility study that's leveraging the aims and infrastructure from my R01 on loneliness and aging and schizophrenia. So that's me. And as Christina was going through some of those things, it struck me as like my Harvard, UCLA, NPI fellowship was 30 years ago. So it made me feel a little bit old. The aging theme is getting less abstract. I'm covering time while I'm trying to figure out how to advance my slides here. They don't want to go. What's going on there? Let me see if this will work. Okay, so this is a quote I like to start with. Dr. Murphy, who's the Surgeon General now, was also Surgeon General during the second term of the Obama administration, and he had put out this quote that I really liked, that during his years of caring for patients, the most common pathology wasn't disease or diabetes, it was loneliness. And Dr. Murphy has really been spearheading examination and addressing loneliness in aging and in other populations as a extremely important public health measure. And he had a whole Surgeon General report that came out either last year or 2022, I forget the precise date, but it's being recognized as something that's really affecting public welfare, public well-being, and early mortality and disability and so forth. Just in terms of terminology, so what is loneliness? Loneliness we think of as psychological distress. And I've underlined distress because that's important in distinguishing it from some other constructs. And it's a distress about this perceived discrepancy between what you see your social relationships or social network as being and what you want them to be. And so that can be in the types of relationships, the number of relationships, or in the quality of those relationships. In contrast, social isolation is, it can be hard to pin this thing down because people use it in different ways. But what we're talking about generally is objective social isolation. And so these are the objectively quantifiable or accountable aspects of your social environment. Like how many social interactions did you have in a day? How many people do you live with? Those types of things. And I'm going to talk a little bit about the difficulties measuring loneliness. Measuring objective social isolation actually turns out to be even harder. Surprisingly, loneliness, or maybe not so surprisingly, loneliness and objective social isolation are generally significantly correlated, but not at a very strong level of about a 0.2 to 0.3 range. I see 0.25 popping up a lot. That's kind of the magic number in psychological research with like trait-like theories. Or traits tend to be correlated with behavior about 0.3. So that correlation shows up a lot in psychology, and it shows up here as well. There's some other terms, and again, these are not used all consistently, but there are other terms you'll hear, and you see them listed here: social disconnection and social connection. Social support be divided into emotional versus instrumental support, and I think that this one is a important intermediate construct between objective social isolation and loneliness. Is this can be who do you have that you can turn to for emotional support when you're feeling strong emotions and you want to talk it through. And in terms of instrumental support, it can be important with the relationship of social isolation to health, in terms of having people to remind you to take your medications, having people to help you get to your medical care, having someone to help push you to go exercise or for a walk, and so forth. And then another term is social detachment. Social detachment is the word you hear in the DSM-5 under PTSD. And so when I initially made this slide, I was focused in on this because I think loneliness in PTSD may be a key problem. It may even be in the diagnostic criteria because the social detachment symptom's been there from the beginning. But there's been almost no research, and when I've tried to get someone to fund me to do the research, they tend to say no. So it's hopefully someone will find an answer there. Another distinction is between solitude versus loneliness, and I forget where I stole this difference between something.com, but solitude can actually be a pleasurable experience, one that people seek out, especially it's voluntary solitude. And I won't read through the whole slide here to you, but again, it's just to underline the point that loneliness is this internal psychological experience that it's not the same as being alone. You can be very lonely in a crowd, or you can be very happy by yourself. I think voluntariness has something to do with that distinction. I've already said this, so I'm going to skip this one. Okay, another thing about loneliness that I'm interested in that doesn't get a lot of airplay for some reason. The center of this slide is just a reiteration of the definition of loneliness. But loneliness, when you hear it talked about in the literature, is generally described as something negative, something to be avoided. But it actually can have positive benefits, and we'll talk about that in a second. But also, loneliness is kind of a superordinate category in terms of describing how one's feeling, because any one person may experience loneliness different. It may be a sense of sadness, it may be a sense of anxiety. For some folks, it may be anger or depression. And the current measures that we have don't do a good job of disentangling these, because it may be when we talk about the biological toxicity of loneliness that the internal phenomenological experience may be important. And certainly when we talk about interventions to prevent or decrease loneliness, the internal experience may be central to guiding the therapies for that. So that's just kind of on my wish list of things for the future. Types of loneliness. Again, in the context of aging, something that struck me is if you think about a freshman college student that's in the first week in the dorms, and the types of loneliness that person might experience. it tends to be a loneliness. It can be about friends who they've left at home, but it can also be a sense of loneliness about and worry about, well, am I going to make any friends? Am I going to have anybody to eat meals with? It's a loneliness that's focused on relationships that don't yet exist, but they're hoping to exist. And then in later life, and again, I'm painting with a broad brush because anyone can have either of these, but in later life, there may be more tendency towards loneliness in the context of bereavement, bereaving a spouse, but bereaving, I've had to move from my home. I miss my mechanic. I miss all the things I'm familiar with as friends start to die. So loneliness there may be more focused on relationships that have been lost. And what the internal experience of those are and whether they matter in some of the biological downstream effects, we don't know. That work hasn't been done yet. And by the way, I should have said in the beginning, I've got about a bazillion slides, and we can go through them all, but I feel no need to go through them all. So if I hit on something, or if you have a question or something's unclear, please just unmute yourself and let me know, and we'll talk about it right as we're going along. Okay, so there's these types of loneliness. People often talk about emotional, social, and community loneliness. I won't read the slide to you because you've had time to read that. But as we talk about measures, we're not really getting the fine-grained nuances of these. So I'm hoping that now there'll be a second wave of measurement development. In terms of social connection, this is from that more, oh no, that's from the older, that's from Holt-Lundstad. I was going to say it was this slide is from last year's social Surgeon General report, but it's actually adapted from this Holt-Lundstad. Holt-Lundstad has really been a pioneer in doing like these large meta-analyses of the effects of loneliness and social isolation. So this is just talking about the different ways you can think about social connection in terms of structure, function, or quality. But I think we've covered that there. Okay, so you'll hear about the epidemic of loneliness, and then you'll hear about prevalence rates. Prevalence rates are interesting for reasons I'll tell you in a minute, but in a nutshell, it depends on where you draw the line and on what basis you draw that line. But if you read the overall literature, most estimates of significant loneliness in the general population are in this range of 16 to 45%. I'd say the majority are in this 20 to 25% range. So that's a conservative estimate, and that's 1 in 4 people having what we think of as clinically significant loneliness. By now, you've all heard of this Minister of Loneliness who was appointed in the UK in 2018. I believe the specific one was like fired within a month for some reason I've forgotten, but it's set off international recognition of the importance of loneliness. I'm not quite sure why I have that stigma bullet point in here. This must be left over from an old slide, but it is true that the stigma of loneliness is a problem. Oh, and because there's this stigma, people may underreport significant loneliness, especially when they are being asked directly. Okay, this bottom bullet point, this really is critical. And this is Holt-Lundstad et al.'s meta-analysis from 2015. They've done others. And what they found was that when they look at all-cause mortality over longitudinal studies, there's a 26 to 52% increase in all-cause mortality. When they boiled it all down and corrected for things that might be confounded between loneliness and all-cause mortality, it still came down to a 26% increase in all-cause mortality, which is about equivalent with a low level of obesity and equivalent with that associated with smoking 14 cigarettes per day. I've been skeptical of that smoking number, but it seems to be pretty solid. It's hard to find the actual study, but I think I found it. And so, yeah, 10 to 14 cigarettes per day, this is about the same number. Okay, that's a duplicate. Well, why it matters, jump down. Loneliness is a risk factor for all these bad things. One, the reason we're here in terms of decreased cognitive performance, but also things like metabolic syndrome, diabetes, cardiovascular disease, sleep, suicide, functional dependence, life satisfaction, and among older adults, increased physical frailty. And so again, the question is, well, why is that? And we don't quite know yet, but we've got some ideas. The increased risk for Alzheimer's disease related dementias, as you can see in this bullet point there, might be as high as 40 to 60%. But this is my favorite point, not all loneliness is maladaptive. And this idea that not all loneliness is maladaptive is part of what motivated the small study I'm going to show you in a second here. There was this recent, it wasn't a meta-analysis, but it was a systematic review of the relationship of loneliness and dementia from Karaska. And here they pulled out the main longitudinal studies. You can see the findings vary to some degree across studies, but overall, this relationship between problematic loneliness and risk of subsequent cognitive decline, including later dementia, seems to be pretty well established. So that really wasn't something I was trying to establish with this small feasibility study. We're going to take that as a given, and more, I'm trying to set the ground for, well, what might we do about that? Okay, so think about, why would loneliness be associated with all these bad things? I mean, it's an aversive experience, but it can also be associated with bad things. So the person who really made loneliness a topic of scientific study was John Cacioppo, who unfortunately passed away just a few years ago. And he and Hockley and a few others have this social neuroscience model of loneliness. And it's quite interesting. And they make the point that acute loneliness is adaptive. If you are, you're thinking of yourselves back in early times, if you're feeling lonely, this can be a social motivating thing that leads you to reach out to other people. And reaching out to other people it decreases your danger of getting eaten by like a mountain lion, increases the probability you'll have something to eat. And being socially connected increases the probability of your genes being represented in the next generation. So for all those reasons, loneliness is actually a thing we need. I think of it as akin to chronic pain, where the inability to experience acute pain is quite problematic, but it's where it becomes chronic or severe that it is something we need to do something about. And the heritability index there, as you can see, is about 0.37 to 0.44 for this ability to experience loneliness. So loneliness is a good thing. It's just not something we want to experience all the time or severely. So it's when it becomes severe under this Cacioppo-Hockley model that things go awry. The model is that it sets off this hypervigilance to social threat, and that sustained hypervigilance can lead you to actually do things that will kind of be self-fulfilling prophecy, and you're acting uncomfortable around people, and that makes other people uncomfortable. So there can be this snowballing. The part I have here is as this loneliness becomes chronic, there's this sustained hyperarousal. And their model is that this leads to this sustained physiologic fight or flight mode that may be associated with chronic inflammation or a disruption in inflammatory response to stress. And the idea here is that this can be biologically toxic, and this may underlie some of the association with cognitive deficits and with other health disorders. But there's another alternative, and this doesn't have to be either or, and that's the behavioral or environmental model, where loneliness might increase negative health behaviors and decrease positive health behaviors. Okay, so I promised to talk a little bit about loneliness. So the gold standard loneliness measure, at least in North America, in Europe, they use a different measure that I'll mention briefly, but in North America and most of the studies is this measured by Russell, the UCLA loneliness scale that's currently in its third edition. I think due for a fourth edition because there's some problems with even the third edition. It's 20 items. It never uses the term lonely, although one item does say alone. And the idea of this has been particularly, there's a gender difference. If you ask people directly, are you feeling lonely? There's some suggestion that males may be less inclined to endorse that, but the gender differences disappear when we use an indirect measure like this. And I'll show you some of the items in a minute. There's positively and negatively worded items. The bunch of abbreviated forms. Russell has developed a 4-item one that's been confirmed with factor analysis. Hughes et al. Back in 2004 developed a 3-item version off of the first revision, or UCLA-R. And I contacted Russell, and Russell had seemed to not be as big of a fan of the 4-item version. I mean, of the 3-item version, because of some of the ways they changed the anchors of the item and so forth. So he had recommended to me that I use the 4-item version. So that's the version that I have been using when I use an abbreviated one. But when you read a lot of epidemiologic surveys, they most frequently use the 3-item version, and this was the one endorsed by in a review by the Institute of Medicine. So just kind of keep that in mind about what's being measured. Here's some items from these are the first 10 items from the UCLA scale, and you can get a sense of those. What I want you to see mostly is these anchors: never, rarely, sometimes, and always. And they go from 1 to 4. And after flipping the ones that are reverse scored, you end up with a total score of 20 to 80, with higher scores representing more loneliness. And then the question is, if you wanted to categorize people in terms of loneliness, where would you put the cut score? Well, notice that if you answered rarely to everything with 20 items, you would already get a score of 40. And I was going to speak for myself. It's hard for me to think of like an emotional experience of the type that would be on here, or almost any psychological scale, that would be comfortable using the extremes of never and always on. And so I feel like you may be stuck a little bit on this this rather subjective distinction between what is rarely versus what is sometimes. On the promise measures, they created a loneliness scale with some of the items, and they used a 5-point scale. And I think that maybe in the UCLA 4, UCLA 4, maybe they'll provide a middle point. Again, I'm a little uncomfortable with the never and always, but just think about those anchors. As you think about, well, I see a particular cut score, what kinds of questions, what kinds of responses would I have to get to get a cut score? And again, I contacted Russell, and he said, any cut score is arbitrary. Here's the thing, actually. He said it's clearly arbitrary. I think this is actually from the normative manual, but he also mentioned this in an email. So what he suggested was, for studies of loneliness interventions, that you might use 2 standard deviations to define very high loneliness, which based on those norms was about 60 points, and a score that was 1 standard deviation might be moderately high. And in my email, I need to find this. Since it's recorded, I have to say this is all hearsay. But my memory is, he was saying 51 points would probably be the lower limit of what you might want for an intervention study to have room to show improvement. So what people have used different scores. I've sometimes needed to adopt one, and I've found this scheme that's been used in some of the oncology research. It's from a master's thesis by Smith back in 1985, and she says right out this is a quote, and so 20 to 34, she used low, 35 to 49 moderate, 50 to 64 as moderately high, and 65 to 80 as high. So this was picked up by Perry in this study, and she noted that these scores were arbitrarily divided, as had been done by Smith. But then it's got people started quoting Perry and have often failed to mention the arbitrary thing. So when you see cut scores, just be skeptical. I will show you some of our preliminary data based on those cut scores anyway. So this is from the Cigna study, and they are looking at individual items. And what you can see is if you're looking at some of the always or sometimes, I still think sometimes is relatively innocuous, but there's a fair degree of endorsement of individual items in the lonely direction. This is from an AARP study. I need to actually update the reference on here. It's more recent. I believe this data was 2018. I don't know why it says 2010. I guess maybe I've got an old thing here, but they've updated in 2018. They did it in 2020, right before the pandemic, unfortunately, and the numbers tend to show up same. There might be a slight increase, and as you can see in this one here, 35% of adults age 45 and above were categorized as lonely, and so you'll see that figure cited or one like it cited. But in asterisk, it says, as measured by a score of 44 or higher on the UCLA loneliness scale. So I do think loneliness is an important phenomena to address, or we wouldn't be sitting here. But again, whenever I see a specific figure, I'm just a little skeptical, because I don't know a good way yet of the good data that has established a good cutoff with sensitivity and specificity. It all feels a little bit subjective. Now, this middle line here, and I'll show you some of our data that goes along with this, actually suggests that loneliness goes down with aging. I think that if we had people over on the left-hand side of that, and I'll show you some data with that, there may be higher loneliness in the early 20s, and then a bump in the 50s, and then a decrease until we get up into the 80s. So this is a study we did with an MTurk sample. I can explain MTurk to you later, but there are people who on Amazon.com agree to do little tasks, including taking, in this case, our survey. So we had a sample of people recruited through MTurk who completed, among other things, this a 4-item version of the UCLA loneliness scale. Don't worry so much about the actual scores, but just the pattern here is, you see down in the 20s, there's higher mean scores. There's a hint of a bump up here in the 50 some, late 40s, some 50 some range, and the statistician said that was a significant one, although it doesn't glare out at me as you're doing visual analysis. And then there's actually this decline that we saw in people in their 60s and 70s. So that was from Tanya Nguyen, who was a student at the JDP and then was a postdoc, and then joined the faculty at here in the Department of Psychiatry, and that was a terrific study. Then Ellen Lee, who's on the faculty here, did this very important study back in 2019, and she found something similar. This was with the full 20-item UCLA. I don't recall why she logged it, but again, what I mostly want you to see is the shape here, that in the earlier years there seems to be this some elevation among people in their 20s. Then there's this bump. Now here the bump seems more like in the late 50s and late 40s. And then there's this decline till about age 80, and then there's this increase. So there does not, when you combine this with other studies, actually, I think I can show you one. Here's some from Hockley. This is Cassiopo's group, and you're seeing some similar things, although the people below age 20 are doing okay. There's this bump in somewhere in the 20s, somewhere in the late 50s, goes down to about age 80, and then it increases again. And here's another study from a different sample from the same group. So something seems to happen to us in our 50s or 60s or late 40s where we tend to be a little bit unhappy. Then we get better. And I had just turned 62, so I'm happy that I'm going to be on this downward slide of this. It's kind of the reverse of this inverted, or not inverted, this U-shaped thing of well-being that people talk about. No, it is an inverted U of that well-being is kind of hits a nadir in around age 50 something, and then well-being starts to go up again with age. So there's something about the 50s, but then it actually gets better for a while. Okay, there is this other scale by De Jong. This one's used more in Europe, and I won't go long into this, except remember I talked about emotional versus social loneliness. So this scale, when they're not using the UCLA, this would be the one to use. And they had done a factor analysis of this scale in the original development, and they found two factors. I've highlighted the ones that are on one of the factors, and you'll notice that they're all negatively worded. They're all worded in the loneliness direction, and then the others are worded in the positive direction. Now you'll see this interpreted as these two factors measuring emotional versus social loneliness. But De Jong Gerveld, I'm sure I mangled their name, said right in the original paper that this is confounded with method variance of negative versus positively worded items. So when you read papers and see these different factors interpreted as emotional versus social loneliness, I would just take that with a grain of salt. It might be, but it hasn't been proven to me yet that that's what's important there. Okay, so now I'll get to our ongoing feasibility study. I already talked about this analogy to acute versus chronic pain, but what we still don't know is, like, what's the boundary between acute versus chronic loneliness? When does loneliness become problematic? And can we identify modifiable factors associated with acute loneliness? That is, we find people who are experiencing acute loneliness, but then make adaptive responses to that, and loneliness goes down, versus people who get stuck in their loneliness and then later teach the factors we learned at people who are having adaptive responses to loneliness to people who are getting stuck in chronic loneliness. Well, there's a whole lot there that we're certainly not going to do with this small study, but that's kind of the overarching goal of where we'd like to go. So this was an administrative supplement, and with an administrative supplement, you need to relate it to the original aims, and the original aims were more focused on in-lab measures, but we did have this exploratory aim where we're using ecological momentary assessment, and Colin Dapp and Ray and Moore were real helpful there. So, talk about other acknowledgements, because that was not my area of expertise. But anyway, when we got this administrative supplement opportunity, we related our key hypothesis to this exploratory aim, and you can read it there. But basically, it's that or the degree of frequent and persistent loneliness would be associated with worse cognitive functioning, functional capacity, physiological markers, health outcome measures among persons with mild cognitive impairment. When I say mild cognitive impairment, also because I've had to make some adjustments, put kind of quotation marks around that, because it might not meet all the most formal definitions. I'll tell you how we define that for some of these folks. We also said we'd look at the EMA defined loneliness patterns relative to the lab-based measures, UCLA. And then we also wanted to examine the cross-leg temporal associates between loneliness, social motivation, social isolation, and affect. Again, with the idea that we want to see if we can find where loneliness is leading to adaptive changes. And I won't have a whole lot of that for you. I've only got some preliminary data here. Our target sample size is 40. Right now we have 28, and I've got data for you today on 27. We've got 5 additional people in process, but we still need 7 people. So if you think of people that might be appropriate and interested, please send them my way. The age range was 50 to 90. And so what we came down to is they're going to have a MoCA score of 18 to 26. They're going to report subjective cognitive concerns, and there's going to be an absence of frank impairment in everyday functioning, and then absence of other factors like current substance abuse or other neurologic conditions that are likely to cause cognitive impairment. We only see them one time. We do a blood draw in the morning, have them do some clinical rating scales. Then we send them off with a smartphone that's going to survey them twice a day with some questions I'll show you. And they also wear an actigraph or actually a Fitbit that we're measuring their activity levels, and we can get some measures on sleep and so forth. And I'm not going to show you all of that, but here's some of the things. Didn't want to busy the slide with everything, but what I'll focus on at the UCLA scale, we've got something called the Duke Social Support Index, which is more towards the objective, kind of countable aspects of your social environment. We've got the SF36. For today, we'll look at the mental and physical health components. We've got the Pittsburgh Sleep Quality Index, which is higher scores on this represent more subjective sleep disturbance. And we're doing the EMA survey twice per day with 14 questions that I'll show you. And then we've got a battery of cognitive tests. One, we've got the MoCA that we're using for screening, but then we administered most of the Matrix Cognitive Consensus battery. And the ones I'll show you some today are the ones highlighted in bold with the speed of processing, working memory, verbal learning, and visual learning component scores from that. We also have a digit vigilance task, Stroop, 15-item Boston naming, and the UPSA brief. I'm not going to show you any of that today. And then you can see the physical measures, and then we've got these inflammatory markers that we also need to assay, and we're not going to talk about today. So this is these are the questions on the survey. The key one for today is this one. Right now I feel lonely, and then they rate it not at all, a little bit, somewhat, quite a bit, or very much. And remember, I said early on, when you ask people directly, sometimes they'll underreport, and that might be happening here, because we'll see we're getting some low endorsement of loneliness. Oops. These screens are like our screenshots. This is what it looks like for the participant. There's the introductory thing. The first question asks about who they're with at this moment. There's a bunch of different questions. I go back to the other slide, and here's the one that we're focused on, though. Right now, I feel lonely, and then they choose. Okay, so far we've got data for 27 people. Here's a general description of them. So you can see they're not the most diverse sample on Earth. The minimum education is 13, and 93% of them are non-Latinx white people. About 48% of them are living at home. The MoCA scores, we were allowing down to 18, but we've got 20 to 26. Most of the mean T-scores from the Matrix battery are close to what we would consider normal. They're still in the average range. This verbal learning T-score of 42 is low, maybe not surprising given the population, but still lower than I would have thought. And there are the lower end of the range of the T-scores. There's one person who's scoring not so well. I need to pull their chart and see what's going on there. But in general, the average scores are still in the average range. Remember I said there's this arbitrary categorization from Smith just to see how frequent loneliness is. So we didn't get anyone in the full severe range, so nobody with a score from 64 to 80. But we did get about 18 who are in this moderately severe range of 49 to 64. This moderate range, this moderate group is 34 to 48. And so it's a little bit lonely. These are the most lonely people. And then these people are doing remarkably well, because that's 20 to 34. And if you just report a couple of things, rarely you're going to get higher than that. So in terms of adherence, I haven't had a chance to look yet and see, like, of all the potential surveys, how many have been completed. But what I did get skepticism that because normally in my main study, I'm surveying people for 7 days. I did get skepticism that I could get people to do this for 60 days. So we ended up actually making it 30 days with an optional 60 days, and a good chunk of people are going for that option. So about 56% of people have completed at least one of the 60-day surveys. 81% completed the 30-day survey, and 89% completed at least the 15-day survey. Because one of the things, and if we do this in a larger thing, I wanted to figure out is how long can we go? I want long, I'd actually like 3 months, but I don't think I can get people to do that. So I could really see runs of lonely days and so forth. But it's just how long can you get people to do this? And I'm not showing you the Fitbit data yet because I haven't downloaded it. Okay, this is just an example of what I want. So I downloaded the actual data. This is all on that loneliness item. And so again, it can run from 1 to 5, with 5 being higher. And this person here that I've highlighted in yellow is just an example of what I kind of hope to see. So we got a relative run of 3s and 4s, 2s, 3s, 4s, some 1s. But then it trails off, and they've got 2s and 1s. So they were lonely for a while, and then not. This person down here, they got a 4, 3, 2, 3, 4, and you follow that out. Even out here, there's still 3. So they seem to be more stuck in loneliness. I don't think I'm going to be able to do this with 40 people. So it's more of a proof of concept. But what I'd like to see is if we could find people like this, people who are there's going to be people who aren't lonely, reporting loneliness at all, but people who are getting stuck in loneliness, people who have periods and are responding to it adaptively. And that's where some of the other questions on the survey about social motivation and how many people did you interact with, I think it could be helpful if we have a larger sample. Just as a validation of the loneliness EMA thing, I did a correlation and just did the first 7 days because I want to do this fast to see if there was the morning loneliness rating, afternoon were correlated, and as you can see, there's pretty good correlation. I think it's about 0.67 if I can do the math in my head right. But so you can see they are related, so that speaks to at least there's some reliability, but they're all clustered up down here in the 1 to 2 range. People really aren't using the 3, 4, 5 range very much there. So that's a little, well, it's good that they're not that lonely, but it's a little disappointing in terms of what I'm getting. Here I did a correlation between that same first 7 days of morning surveys of loneliness and the UCLA scale. And there is a reasonable correlation. The one with afternoon loneliness is actually up in that 0.6 something range. So the correlation of afternoon loneliness and the UCLA scale is almost what the correlation of the afternoon and morning are. So I think we're probably bumping up on the reliability of the EMA loneliness rating anyway. So that was a pleasant surprise. Now then, some other bivariate correlations. Unfortunately, actually, the top half of this is with the cognitive scores. We're not finding significant correlations with our cognitive scores. There is a correlation with the mental health component, which would be concerning if there wasn't one, so that the more lonely you're feeling, the lower you're feeling in terms of your mental health functional capacity. There's some relationship with worse sleep disturbance here, and there's also some modest association with objective social support. Okay. Just to look at it, I want to look at this working memory one because it wasn't significant, but it was the highest of 0.29. And you can see there's some trend there, but it's in the wrong direction. What we were expecting was that higher loneliness would be associated with worse memory. And what this makes me think about, and I found this in a different sample, is the cross-sectional thing does not work. I'm making up post hoc explanations here, but I'm thinking maybe you have to have some degree of ability to stop and pause and reflect on your situation, to notice that you're feeling lonely, and so that cross-sectionally that something like working memory may be modestly associated with a loneliness score. And there's so many other factors other than this loneliness score cross-sectionally that may explain heterogeneity between participants, that it may be that we really need to look at this longitudinally. It's just not possible within the constraints of a admit supplement. So things to do: I have to finish recruitment. I need to test the a priori hypothesis that I set up, examine the percent of surveys completed, the Fitbit data, and this last one, where possible, I want to examine whatever patterns we find and see if they are specific or similar to the ones we find in schizophrenia and our non-SMI control group. I like this slide because this is the pale blue dot taken by one of the Voyager spacecraft, but I won't go into that in the interest of time. So I'll stop there and take questions or comments and so forth.